afternoon. So good afternoon, everyone. Thank you so much for joining us today. I am Amal Khoury, Director of the Center for Applied Research and Evaluation in Women's Health at ETSU. And on behalf of the center and my colleagues, I'm very pleased to welcome you to the Health for Her seminar for February 2021, our first seminar for this year. And I'm very delighted, to welcome this afternoon Dr. Nancy Fleischer, who is joining us from Ann Arbor, Michigan. Dr. Fleischer, thank you for your time. We really appreciate having you today. Dr. Fleischer is a social epidemiologist, and her research focuses on how social and policy determinants affect health and health equity. Certainly a very timely and important, area of study at this time. Dr. Fleischer holds a PhD in epidemiology from the University of Michigan and an MPH from the University of California in Berkeley. Interestingly, though, before starting her graduate studies, she served for nearly 3 years as a Peace Corps volunteer. And after that, she worked in occupational health at the California Department of Public Health. So she started her graduate studies with a wealth of international and practice experience that I'm sure have, shaped not only her graduate studies, but, continue to shape her career at this time. Dr. Fleischer served as an Epidemic Intelligence Service Fellow after completing her PhD with the Centers for Disease Control and Prevention. She then started her academic career as an assistant professor at the University of South Carolina. And I know we have folks on the call today from USC. She is currently an associate professor of epidemiology at the University of Michigan, where she studies how tobacco control policies affect health equity and how structural racism affects birth outcomes and COVID-19 recovery. Dr. Fleischer is affiliated with the Health Equity Law and Policy in Epidemiologic Research Team at Michigan and with the Center for the Assessment of Tobacco Regulations. She has a very, very impressive CV. Again, lots of productivity in grant work and in publications and presentations in order to disseminate her work and make, the important contributions that she is making. So with that, I'm going to turn it over to Dr. Fleischer, and we are all looking forward to your presentation. Thank you.
Well, thank you very much for the kind introduction, and thank you for the invitation to come and speak with you today. It's nice to see a different set of people in my squares on my computer. And I know that Mike Smith can't be here today, but he was the one who invited me to come and present this work. And really, this work started because of him. So I want to acknowledge him also in that. And I'm pleased to share this work with you today. So let me just move my little video squares around so I can see the presentation. And so today I'll be talking to you about understanding disparities and specifically racial disparities in adverse birth outcomes in South Carolina using a life course lens. And so first I want to just introduce you a little bit to how I think about problems and how I approach the world as a social epidemiologist, and then talk to you about what racial ethnic disparities we see in adverse birth outcomes and how we can start to think about those within the context of racism and structural racism. And then I'll share with you what we hope is just the start of this work, but it's an analysis where we're using a life course lens to understand social mobility across generations to be able to look at that relationship to adverse birth outcomes. And then I'll end by talking about where I hope this work will go if we get this work funded, to look upstream to understand these racial and ethnic disparities in birth outcomes. So for those of you who maybe haven't heard of social epidemiology before, this is the branch of epidemiology where we're really thinking about how social structures and institutions and relationships influence health. And so we're concerned not just with overall levels of population health, but really importantly, how health is distributed within populations. And I like to use this framework from the WHO, from the Social Determinants of Health Commission to orient how I think about the world. And so I don't know if you can see my cursor. Can you see my cursor? On the left-hand side, we have sort of these structural determinants of health and health inequities, starting with our socioeconomic and political context, which influences social class, which then works on these sort of intermediary determinants and social determinants of health to impact health equity. And I really focus in my research on thinking about how this socio and economic and political context through policy is affecting social position and how that kind of works to affect health equity. And as Amal mentioned, much of my work has been looking at tobacco control policies and health equity, and recently been moving into the area of thinking more along the lines of social policies rather than health policies, and how social policies, including policies related to structural racism, are affecting health and health equity. So moving on to talking about what we see in terms of racial and ethnic disparities in adverse birth outcomes in South Carolina. So South Carolina has a population of just over 5 million people. About 64% are non-Hispanic white, about 26% are non-Hispanic Black, and about nearly 6% of the population is Hispanic. South Carolina, and many, as is true in many places, has had long-standing racial disparities in birth outcomes. So this graph looks at trends in preterm birth in South Carolina from 1990 to 2018, and the dashed lines represent non-Hispanic white population, and the solid line represents a non-Hispanic Black population. And you can see an upward trend during the 90s, leveling out in the early 2000s for preterm birth in general, but this very persistent gap, which has been sort of a sustaining feature over time of racial disparities in preterm birth. And we see a similar sort of gap and persistence of that gap over time in low birth weight by race in South Carolina during the same time period. So to begin to understand these persistent disparities in racial outcomes for birth outcomes, we need to acknowledge the role that racism plays. And I like this sort of framing of thinking about the different levels of racism. So we can think about institutionalized racism or structural racism, where we have structural barriers that are put into place via policies that affect societal norms. We can think of racism that's personally mediated, which is, I think, what people mostly think of when they think of racism, sort of acts between individuals, and then internalized racism. And because I think, I'm a very upstream thinker, and I think a lot about how societal structures influence health, I'm really interested in this sort of outer layer of institutional racism. So institutional racism or structural racism is the system of policies, of practices, of ideologies, and of institutions that really foster racial inequality. And they foster racial inequality in health outcomes by creating differential access to resources and to opportunities. So we see this in the criminal justice system, we see it in housing and residential segregation, we see it in economic opportunities and in educational opportunities. In South Carolina, we need to acknowledge the history that structural racism has played in the state. South Carolina played a leading role in the nation's slave trade. Nearly 40% of Africans arrived to the US through the port of Charleston. and slave labor was really central to the state's economic wealth and standing. And this history has shaped contemporary structural barriers as well. So there are ongoing barriers to social and economic advancement for Black South Carolinians, for example, through continued school segregation and a persistent economic gap between Black and white residents that really hasn't improved in the past several decades. So with this backdrop of structural racism, we want to be thinking how these policies and practices are really affecting individuals and leading to these disparities in adverse birth outcomes using a life course lens. And so when I talk about life course epidemiology, I'm talking about the study of long-term effects on later health or disease risk of physical or social exposures that can occur kind of across the life course during gestation, childhood, adolescence, young adulthood, and into later adult life. And we're really trying to understand how these different processes operate both across an individual's life course, but also across generations. And the work that I'll be talking to you about today is really focused on social exposures occurring during gestation, and then really how that can be transmitted across generations. And there are a couple of sort of causal models that people use to think about how life course processes work. And they are referred to the accumulation model and the chain of risk model. And so this model, these two examples that I'm showing you right now are the accumulation models. And that's the idea that life course exposures gradually accumulate throughout the life course and can affect health and illness due to sort of this gradual accumulation. And so in model A, these exposures A, B, and C are acting independently. And in model B, we have sort of a clustering of these different exposures by this other factor D. And another model we can think about is a chain of risk model, where there's a sequence of linked exposures over time. So one exposure, for example, exposure A in model C, is affecting or increasing the risk for a subsequent exposure. And this can sort of happen as in model D, just independent, or they have sort of this increasing sequence of risk, but another option is model C, where these factors have their own sort of relationship with health outcomes in addition to increasing risk for additional factors. And so, you know, I'm not sure that the work that I'll be presenting today fits neatly into one or the other. I kind of think of them in a couple of ways. So I certainly think of social factors as being kind of clustered based on opportunity, and in the context that I'm thinking about the opportunities that are shaped via structural racism. But I also think that there is this potential for this accumulation over time and across generations. So then we also need to be thinking about the timing of causal actions in different ways. And so, you know, three different ways that people think about the timing of exposure include birth cohorts, for example, so the year or years when people are born. So I'm sure that for many years into the future, we'll be talking about the birth cohort of children born during the pandemic and how that's affected their life course. We can also be thinking about critical periods, which are really these limited time windows when exposure can have an adverse or a protective effect on development and subsequent disease outcome. And we think of gestation as sort of a prime example of the critical period. And then the sensitive period, like the critical period, an exposure has sort of a stronger impact during that time on later health outcomes. And we often think of childhood as an important example of a sensitive period. And so, you know, really in the work I'll share with you today, I'm really thinking about the critical period of gestation. But we can think about how, even if we're looking at a critical period of gestation and preconception to birth, that, you know, one's one's path through life is affected by many different social environments, at home, at school, into the workforce, and then that subsequently can affect the next generation. So I'm hoping that taking a life course approach can help us to better understand how these social conditions across generations can affect birth outcomes, and importantly, these sort of persistent disparities in birth outcomes that we see by race. So we know that poor socioeconomic environments contribute to worse birth outcomes across generations. So there have been studies looking at exposures to mothers when they themselves were in utero, or when they themselves from their own childhoods, and how those exposures have affected birth outcomes. And also studies looking at the intergenerational transmission of low birth weight and preterm birth, and how socioeconomic factors can affect that intergenerational transmission. And so sort of within that life course framework, we can also be thinking about how these racial discrimination pathways can be sort of layered on top of that. And we can be thinking about how institutional racism is affecting the policy landscape. It's affecting things like residential segregation, unequal schooling, incarceration, and how that is affecting individuals' ability to obtain an education, be gainfully employed, and make a living wage, an income where they can support their families, and how this can also restrict opportunities across generations in terms of socioeconomic status and social mobility. And that has implications for these proximal pathways, including stress pathways, which affect behaviors, psychological responses, physiologic responses, and then eventually these health outcomes, and in this case, adverse birth outcomes.
Those time slots you'd like to have.
And so today I want to share with you a paper that was published a couple of years ago now in Maternal and Child Health Journal. And this project, as I mentioned, started when both Mike Smith and I were at the University of South Carolina, and Mike was working at the Department of Health and Environmental Control at the time, and really told me about this possibility of being able to link birth certificate data across generations. And so, you know, it's been sort of a slow moving project, but we've been making progress. And our first step was to create this multi-generational linked birth data set, and to look at developing some different measures of social mobility across generations. And so the short-term goal was to develop this linked data set in this southern state with a large rural region. And as we've noted, these sort of persistent racial and ethnic disparities in adverse birth outcomes. And there have been a few other studies that have linked birth certificate data over time, but they've been in states that more northern states, and states that don't have as large of rural population or as large of a Black population. But long term, we're hoping to use these data to really understand how different dimensions of structural racism affect social mobility and racial disparities in adverse birth outcomes across generations. So our data are coming from the South Carolina Department of Health and Environmental Control, Vital Statistics. And we start with 1,366,288 singleton births between 1989 and 2014. And DHEC was able to create unique individual identifiers for every mother and child on a birth certificate. And then they basically de-identified those identifiers to share the data with us. And we were then able to link data by mother using identifiers across generations, and then organize the data into family tree structure. And so I'll be talking about these 3 generations today. So G1 grandparents, and information on G1 grandparents are coming from birth certificates for generation 2. So when generation 1 mothers gave birth to generation 2 mothers, we have information on those birth certificates. And then generation 2 are the parents of the children on the generation 3 birth certificates. And so we get information on the parents both from their own birth certificates, these mothers' own birth certificates, as well as their children's birth certificates. And we're looking at 2 birth outcome measures: preterm birth, defined as gestation less than 37 weeks, and low birth weight, looking at birth weights below 2,500 grams. And then we're looking at 3 markers of socioeconomic status. So maternal and paternal education, we're able to look at kind of a range of education levels. Less than 8th grade, 9th to 12th grade, but no diploma, high school diploma, some college, but no degree, an associate's degree, or having a college degree or more. We're also using the availability of paternal information on a birth certificate as a marker of socioeconomic status. And this, the lack of paternal information on a birth certificate has been shown to be related to adverse birth outcomes in other studies, and may represent sort of a lack of support from the paternal side. And then the method of payment is another, for delivery, is another marker that we use. This is only available starting with the 2004 birth certificates, but we look at payment as having private insurance, or being paid by Medicaid, or some of these other ways. We then take these single indicators, or these different indicators of socioeconomic status, and create cross-generational social mobility measures. And so first we take the maternal educational attainment for G1 mothers and generation 2 mothers. And we classify someone as having a high educational attainment if they had more than a high school degree and low otherwise. And then we classify them across generations. So families that had low education for G1 mothers and G2 mothers are classified as always disadvantaged, upwardly mobile if they were low in the first generation but high in the second, downwardly mobile if they were high in the first and low in the second, and always advantaged if they had high levels of education for both G1 and G2 mothers. And we created a similar indicator for paternal education and for G1 and G2 fathers when that information was available, and also created an indicator for paternal information for G1 and G2 fathers. So if they had no information for either generation, if they had information for one generation but not the other, or if they had information for both generations, so on both birth certificates. And then we also created one cross-generational composite social mobility measure. And so we classified G1 social class as a composite of the mother's educational level, the father's educational level, and paternal information being available. And so they could score up to 3 points if they had high levels for each of those 3 markers. And we classified into low, middle, and high. For the G2 generation, we used the same 3 indicators, and then we also used the payment source at delivery. So we gave 1 point for private insurance and 0 otherwise. And then to combine across the 2 generations, we created this 9-category variable of social mobility. So always disadvantaged would be low in both generations. Upwardly mobile could be low to middle, or low to high, or middle to high. Downwardly mobile could be middle to low, or high to middle, or high to low. Always middle level, and then an always advantage level. So to give you a sense of how our data fit together, we started with all of the live births in South Carolina between 1989 and 2014, and then restricted those to just the singleton births. And we were able to link across generations in this multi-generational data set with just over 100,000 total birth certificates for generation 2 and generation 3. And those 100,000 birth certificates represented 61,229 linked linked data across the 3 generations. And so from those linked data, almost all of those birth certificates had educational information available for both generation 1 and generation 2 mothers. But just over half had it for either generation 1 fathers or generation 2 fathers. And when we combine them, just short of 20,000 families had educational information available for both G1 and G2 fathers. And then having information available for both the mothers and the fathers was just a little bit lower than that. So our first step was to compare our multi-generational sample to all singleton births, because when we worked on these data, the most available, the recently available birth certificate data was from 2014. We restricted one of our comparison groups to the data set of births to women who were less than or equal to 25 years old and had births in the G3 birth years. And so since our birth certificate started from 1989 and went to 2014, the oldest a mother in the second generation could be was 25, which is why we restricted to 25 years. And then our G3 births were between 2001 and 2014, which is why we restricted to those. So you can see that even after we made that age restriction, though, our multi-generational sample for G3 births, mothers and fathers were both younger than the comparison data set. They were also more commonly Black and less commonly Hispanic. And that is due in large part because we required that the mothers to be in the multi-generational sample be born in South Carolina. And so since many members of the Hispanic population in South Carolina are not born in South Carolina, they did not have the opportunity to be part of the multi-generational data set. We did find that preterm birth was similar between our multi-generational sample and our full data set comparison group, but that low birth weight was higher in our multi-generational sample as compared to the full data set. Next, I want to talk to you just a little bit about the characteristics of our multi-generational data set. So the G1 mothers were 23.4 years old on average, and mostly either non-Hispanic Black or non-Hispanic white. They had relatively low levels of education, so the vast majority had a high school diploma or less. G1 fathers were slightly older than G1 mothers, and about 27.5 years old on average, and nearly half, 46.5%, had missing information for race, ethnicity, and other variables. And the remaining 36.2% were white and 16.4% were Black. Nearly half of G1 fathers were also missing information on education, and educational attainment for those who did have data was similarly low as with the G1 mothers. G2 mothers were younger on average than the G1 mothers, and that's due to just the length of time that we had birth certificate data available at the time. And again, mostly non-Hispanic Black and non-Hispanic white. A higher proportion of G2 mothers completed some college or more, so 25.9% compared to G1 mothers, which was only just shy of 15%. G2 fathers were 23 years old on average, and they had similar amounts of missing information for race for G1 and G2 fathers, and slightly higher proportion of Black fathers in G2. G2 fathers with information on educational attainment had higher education on average than G1 fathers, which was similar to what we saw when we compared the mothers. And then just a little bit about the births from our third generation. The vast majority were funded by Medicaid, over 81%, and about 15% were funded by private insurance, which was how we defined our sort of higher socioeconomic measure for the birth data. Preterm birth was most common among G3 infants who were born to either non-Hispanic Black or other racial ethnic mothers. And low birth weight was most common for G3 infants born to non-Hispanic Black mothers. So the next series of graphs I'm going to show you are our markers of social mobility. And so I'll just walk you through in a little bit of detail on this first one, how we're laying these out. So we have the race of the G2 mother on our x-axis, and then proportion on our y-axis. The blue to the left is this always advantaged category, so staying at high levels of socioeconomic status across generations. The black bars relate to upward mobility, so going from a low level of socioeconomic status to a high level. Downwardly mobile is this gray color, and then always advantaged is always disadvantaged, so staying at low levels of socioeconomic status is this yellow color. And so this graph is focused on maternal education. And we saw that most G3 children were born to families that were always disadvantaged. However, almost 20% were born to upwardly mobile families. And that was slightly more common for white and Black families than for Hispanic and other families. When we looked at the marker of paternal education, we saw that patterns were similar to maternal education, but upward mobility was more pronounced among Black and white families than Hispanic families. When we looked at paternal information, 27% had no paternal information for both G1 and G2. And paternal information was most limited across generations for Black families and most available for white families. So we see that 55% of white families always had information on fathers on the birth certificates across generations. On the other hand, we see that Black families had only 13% of birth certificates, G3 births always had information across both generations. And 43% did not have information on either birth certificate. And this graph represents our sort of combined social mobility score. And so we collapsed some of the categories. So you were looking at 9 bars for each race group. So we have the always advantaged, again, in the blue, upwardly mobile. So that could be from low to middle, low to high, or middle to high. Downwardly mobile, which could be high to middle, or middle to low, and then always disadvantaged, so staying at lower levels of socioeconomic status. We saw that Black families were the most upwardly mobile of all the racial ethnic groups at nearly 40%, but we did see that families of color were more disproportionately disadvantaged over time. So Black families had nearly 30%, were disadvantaged across both generations, compared to 13% for Hispanic, 16% for non-Hispanic other families, and just 6.3% for white families. So when we created this multi-generational data set, we found that multi-generational mothers and fathers were younger than our comparison group with the full birth certificate data. They also had lower education and were less likely to be Hispanic. And also we saw that G3 infants had a lower birth weight than our comparison group. Black families were more likely to begin with lower social mobility scores, but they also had more dynamic changes across generations compared to white families. And so, some of the questions that we have from this are, how do these sort of dynamic cross-generational changes affect adverse birth outcomes? And also, what role does structural racism play in these dynamics? So, of course, we have limitations for our data. Our multi-generational data set is not very representative of the Hispanic population in South Carolina, and this is due to the requirement of having birth certificates for the G2 mothers. So the G2 mothers needed to be born in South Carolina as well. And as I mentioned earlier, many members of the Hispanic population in South Carolina were not born there in previous generations. So that limited our ability to look at that population in our multi-generational data set. We also, due to the limit of the years on the years of birth certificate data that we had available when we started this project, the oldest G2 mother could be was 25 years old. And so with an upcoming grant application, we're planning to incorporate more data. So through 2020, 2021, which will expand our age range for our G2 mothers and make it likely more representative of the South Carolina population as a whole. So our next steps with these data, as I mentioned, this was just sort of our first step, and this has been sort of a slow moving project with very small pots of money over time, but we're hoping to be able to really expand this work and build on what we've developed with the multi-generational data set. And we're planning to link our social mobility measures and look at their relationship to racial disparities in preterm birth and low birth weight in South Carolina. And we also put in a grant application last summer that we are putting in a resubmission for in this summer to look further upstream to really understand the role of structural racism on racial differences in social mobility and adverse birth outcomes. So I'll just finish with sort of a preview of the work that we hope to do to really look upstream. So if we again revisit this pathway of how racial discrimination can affect health, what we're really interested in is how institutional racism or structural racism is affecting policies that affect opportunities differentially by race, which can then affect these persistent disparities in adverse birth outcomes by race. So what we're hoping to do in our grant is be able to look at how exposure to structural racism during pregnancy for both G1 grandmothers and G2 mothers affects birth outcomes. So we're hoping to look at how exposure to structural racism during pregnancy for G1 mothers is affecting birth outcomes, both for their children, but also across the generations for their grandchildren, to look at how exposure to structural racism during pregnancy for mothers in this generation 2 is affecting disparities in birth outcomes for the generation 3 children, and then to look at how this sort of multi-generational perspective or across generations can really give us insight into these persistent disparities over time. So I want to acknowledge my study team that's been working with me slowly but surely on developing these ideas over time. And as I mentioned, Mike Smith was the reason that all of this work started in the first place, and I'm grateful for him for pointing out the possibility with the birth certificate data in South Carolina. And then we've been working closely with Danny Nicheva at South Carolina Department of Health and Environmental Control to be able to code out all of those birth certificates with unique identifiers and get us a data set that we could construct into this family tree structure. And also I want to acknowledge my colleagues, Annie Rowe, Claire Margerson, Belinda Needham, and Andrea Henderson, who have all been part of the many year-long process to write the grant to look at structural racism and disparities in birth outcomes that we hope to get funded one day. So thank you very much for your attention and time, and I'm happy to take any questions.
Thank you, Dr. Fleischer. Thank you very much. That was very, interesting. And my understanding is this data set that was created is a pretty, unique data set. So
Yeah, there have been a few other states that have created sort of these multi-generational data sets, but not many. And it's my understanding from Mike, and you could ask him more, that very few states actually have the capability to do this sort of linking across generations. And so that really makes this data set really unique and important.
Great. Well, thank you again. We do have, some time for discussion, questions, thoughts, ideas that you'd like to share with Dr. Fleischer. So Molly, how would you like to do this? Shall we ask folks, who have a question to raise their hand, or to go ahead and ask their question, unmute and ask their question?
Sure, I think just unmuting and asking is a good way to do it.
Okay. Okay, and I can also keep a look at the chat. So we do have a question. First of all, thanks to Julia and our colleagues who appreciated, the talk. We do have a question from our colleague, Kristen Minnick, and her question is: can you speak to the data sharing process with the vital records?
Sure. So we put in a data use agreement for them to be able to share the data with us. And we also, I put in a contract for them to be able to create these unique identifiers for us, because that was not part of their usual work. And so, so we put in a contract to create the identifiers, and then they de-identify those unique identifiers, and then they were able to share the data with us through this data use agreement between the University of Michigan and South Carolina DHEC.
Okay. Thank you. And the next question is from Dr. Menalou, and he asks, is there a minimum number of generations we need for this kind of research? And can we do similar research with only 2 generations?
That's a good question. So what we have in regular birth certificate data is basically 2 generations, right? The generation of births and then the generation of their parents. And so to be able to get insight beyond that, we need at least 1 additional generation, which is what we've created in this data set. But I think, based on data limitations, at least for birth certificate data, it's harder to go kind of beyond that right now, because things weren't digitized as nicely, and data aren't, and data collection processes also change over time. So yeah, to look beyond kind of what we have in standard birth certificates right now, we need to have at least 1 additional generation to be able to look at that.
Okay, thank you. And folks, if you have follow-up, questions, again, please feel free to add, these to the chat, or again, you can just unmute and speak. Other questions, thoughts? And Nancy, I will, ask, I guess, a question. And again, understanding the uniqueness of the data set, and really the challenges of studying, structural racism across multiple generations. I mean, I'm really intrigued by this, research question, and how you guys have sort of simplified it and presented it, graphically, despite, its complexities. But what are you hoping, or how are you hoping? And I'm not trying to get ahead of the research, but I'm always, as a policy, person, I'm always interested in the implications of the work. So I guess in what ways do you, see this work contributing to policy change, or to just societal advances
Yeah, I think
in this area?
Yeah, I think that's a great question and something that I think about a lot as well. So with the grant, we are proposing to look at different domains of structural racism. So incarceration and criminal justice, education and school quality, economic opportunity, and residential segregation and housing inequalities. And by looking at those different domains, we can start to understand maybe which sectors are most important for specific health outcomes. And so, it may be that the educational sector is incredibly important for birth outcomes. And so if that's true, then we can think about policies related to the educational sector that might be important targets to be able to improve birth outcomes. But, we know that it would likely improve other health outcomes as well. So in the grant, we're really hoping to kind of distinguish between different domains and see if, some domains are more salient for particular health outcomes than others. As part of this sort of years-long process of starting to think about structural racism measurement and how it's linked to birth outcomes, we're also working on a paper that's been another very slow-moving long-term project, but focused on measurement and how, in the literature right now, there's often kind of a loose connection between policy and the measurement that we use for structural racism. And so what we're trying to do in the paper is really lay out a set of policies that we know have affected opportunity over time for different racial and ethnic groups, and then try as best we can with the limitations that we have with data to be able to connect the measures that we're using to measure structural racism back to policies. But I think that that's a really important area of growth for this field.
That's very exciting. What's very, very important. And I did notice, the domains on one of the slides, but thank you for highlighting that. And because certainly, I mean, as you mentioned, structural racism can be very broad and can influence, these outcomes in many different ways. So to be able to look, at different pathways of influence and assess the associations at the domain level, I think will allow for, again, more targeted, recommendations that hopefully will facilitate, again, the translation of these recommendations into action.
Yes, absolutely.
Okay, and I believe we have another question in the chat. This is from our colleague in the College of Pharmacy, Dr. Dowling McClay. I might have missed this detail early on, but are some mothers represented more than once in the data if they had multiple births in the time frame, or was this limited to one birth only?
Yes, I didn't mention that, but it is, yes, it is possible for mothers to be in the data set more than once. And we, although I don't have the exact numbers for you, we know that's true because we had 100,000 total birth certificates. And if it had only been, sort of a one-to-one connection, it would have been about 50,000 sort of families, but we have over 60,000 families. And so we know that mothers and grandmothers are represented more than once and have the ability to be represented more than once.
Does that represent, I guess, any methodological challenges?
Yeah, I mean, it can, since we haven't really been doing regression modeling yet, but we have to be thinking about how the outcomes can be linked, due to nesting within the same mother. So 2 children being nested within the same mother has implications for modeling. So we would want to control for, that clustering within mothers or within grandmothers.
Well, I'm sure Dr. Smith will figure a solution. And also, I mean, I know you're working on, as you mentioned, the resubmission, of the grant proposal. And so congratulations on the initial score and,
Yes, we
and
did
the
pretty well.
feedback. Again, that's an accomplishment, to have an RO1 scored on first submission, and a very, very good score.
Yeah, we were pleased. Yeah, we were pleased it did well, and that gives us hope for funding on resubmission.
Okay. Other, thoughts or questions or comments that anyone would like to contribute in the remaining couple of minutes? Okay, well, in that case, again, thank you all for joining us today. Dr. Fleischer, thank you very much. This was very, informative, and I'm sure will trigger a lot of discussion and idea generation, among our team here. Best wishes with your grant submission. And hopefully we will have the opportunity to connect again in the near future as you continue your work, and so we can learn more.
Thank you very much for having me.